Good evening, everyone. It's so nice to see all of you here this evening, and thank you so much for joining us and celebrating the successes of our past heart-to-heart grant recipients and discuss how we are endowing the future of women's cardiac care and research. My name is Jenny Hansen, and for the past 4 years, I've had the honor of serving on the Alpha Phi Foundation Board of Directors. It is my privilege to be with you this evening, co-moderating this event in our Leading with Heart Impact series. Tonight, we will hear about the progress of our Leading with Heart campaign, as well as the cutting edge programming and research our heart-to-heart partners are conducting to mitigate the challenges women disproportionately face when it comes to cardiac care. This is something that is near and dear to my heart, not only as a woman, but as a mother and the granddaughter of a woman who passed from heart disease. We are grateful to have the opportunity to connect here with sisters, as well as friends and family of Alpha Phi, who have made possible the Foundation's impact on women's heart health. Thank you for your prevailing loyalty and support to Alpha Phi. To introduce herself and share her continued leadership and service to Alpha Phi, I am pleased to turn the mic over to our co-moderator, Dr. Jennifer Freeman.
Thanks, Jenny. Hi, everyone. My name is Dr. Jennifer Freeman, and for several years, I've been a medical reader. And then for about the last 5 years, I've been a part of the Heart to Heart Advisory Council. Thank you again for spending time with us to help celebrate the impact of the Heart to Heart grant over the years and our monumental plans going forward for supporting women's cardiac care and research in perpetuity. The critical need for deepened understanding, differentiated treatments, and effective prevention in women's heart health has only risen since Alpha Phi selected heart health as its philanthropic focus years ago. Alpha Phi Foundation established the Heart to Heart grant in 1993 to provide annual funding for important research and education that improves heart health outcomes for women. Since inception, we've invested over $1.4 million to fund more than 30 cutting-edge research and educational projects. Without the support of loyal Alpha Phi Foundation donors, this program would not be possible. So thank you very much for your continued support.
Thank you, Jennifer. Our Heart to Heart grant recipients will be introducing themselves shortly, but before we jump in, we have a few points of housekeeping for the panel. If you're interested in submitting a question to our panelists, please use the chat feature and send directly to our program manager, Alex Goodman, and she will pass the questions along to us. To introduce themselves and share the topic of their cardiovascular research that earned them the Heart to Heart grant, I turn the mic over to our first panelist, Dr. Erica Spatz of the Yale School of Medicine. Dr. Spatz.
Thank you, Jenny. It's really nice to be here with everyone. I was the 2018 recipient for the Heart to Heart grant, and our study looked to understand better ways to support women in having conversations with their healthcare providers around their cardiovascular risk, as well as the decision on whether to go on a statin medication, a cholesterol lowering medication, which so many women face, especially as they age. This work has led us to have multiple group sessions with women. Our model was based on a peer model and many of you participated, the board participated, and many of the staff from Alpha Phi in our very early sessions as we stumbled through really trying to make these sessions really live and bring out the really hard things about talking about cardiovascular risk factors and health with people's physicians so that we could incorporate them in tools, in our language, in our visual materials that would facilitate these kinds of conversations. So since we've met, we've done more than 10 of these group sessions, really trying to engage diverse groups of women, diversity in terms of age, race, ethnicity, as well as different medical backgrounds. So some people who were, never saw a doctor before, never had these conversations, to women who were already had cardiovascular disease and were still trying to figure out ways to understand how to go forward, how to live their healthiest life. I can also say that the work was never narrowed to just the decision around statins. We quickly learned that women wanted to talk about a lot of different things that they were struggling with making decisions around related to their cardiovascular health. And so the work that we've been doing has led us to go on to achieve more, to get additional grant funding to support women's health at Yale. And we are currently doing studies to offer women better diagnosis for their chest pains, as well as more personalized conversations in a more consultative fashion around decisions like statins, or decisions in how to reduce their cardiovascular risk more globally. In the question and answer session, I'd be happy to share just some more nuances about that kind of work, but I will stop there because this is just an introduction. But I'm really grateful for the support of Alpha Phi in many ways, just supporting this project, but also for your feedback and advice along the way. I've come to you throughout the life of this grant, and I really appreciate your insights and support.
Thank you so much, and I'm sure we'll get into the nitty-gritty of it later, so thank you. Dr. Mumma, would you like to go next?
Sure, thank you. So I'm Bryn Mumma. I'm an associate professor of emergency medicine at UC Davis. And while my clinical practice is broad and I see, everyone who comes into the emergency departments, from heart attacks to trauma patients to broken bones, my research really focuses on cardiovascular emergencies with a focus on sex and gender differences in the diagnosis, treatment, and outcomes of cardiovascular emergencies. My specific heart-to-heart grant focused on evaluating the diagnosis of heart attack and heart injuries in patients who come into the emergency department with chest pain. Our emergency department and every other emergency department around the country sees thousands of patients who come in with chest pain every year. And a very small number of those are having a heart attack or heart injury, but one of our most important jobs is figuring out who's having a heart attack and then who needs additional cardiac testing, and how to have those conversations with people and how to identify who needs the testing. So the main blood test that's used to diagnose a heart attack is called a cardiac troponin level. The newest version of this troponin test is called a high sensitivity troponin test. And it was, excitingly, the first troponin test to be approved by the Food and Drug Administration for use with either a combined cut point, meaning the same cut point for both men and women, which is what we've always had in the past, or sex-specific cut points, meaning a different cut point for men versus women. So in our study, we looked at how men's and women's diagnoses of heart attack and heart injury changed when we used the older assay versus the newer high sensitivity assay. And then also within the high sensitivity assay, we used the combined cut points versus the sex-specific cut points. And then we're also evaluating the addition of sex in addition to some commonly used sort of risk stratification tools that we use in the emergency department to decide who needs future testing to identify their risk of a future heart attack.
Thank you for sharing that. Look forward to hearing more about that during our panel. Dr. Santillan, you are next.
Thank you. Just want to thank all of the members for their support. So as a woman and a researcher and a heart patient, I appreciate all of the support that you do and the awareness that you raise. I am an associate professor at the University of Iowa in the Department of Obstetrics and Gynecology, and I'm the vice chair for research there. My lab really focuses on hypertensive disorders of pregnancy and improving the long-term health of women. Pregnancy is a window to the future health of women. And so if you have preeclampsia, hypertensive disorder during pregnancy, your risk for chronic hypertension goes way up, and for cardiovascular disease. And so we want to understand that risk. And to the kids that are born to women with hypertensive diseases during pregnancy, they're at higher risk for hypertension later on. And so how to modulate that. But really the focus of our Alpha Phi grant was to get to the basics, because women have been left out of research for so long, and especially pregnant women. And so when the new guidelines were issued for how to take a blood pressure properly, which should be something that we really understand, pregnant women weren't included in that study. And so this grant is to rectify that and to find out what happens if a woman is in clinic and she gets her blood pressure taken and it's high, then she's sent to labor and delivery for monitoring, but now she's laying down in a hospital bed. And so is her blood pressure artificially lowered because she's laying in a hospital bed? And if she's in different positions, like they lay you on your left side, or if you're in your normal semi-follower position, how does that affect your blood pressure? And so there's actually been very little done on something that is considered a vital measurement, right? That's why we call them vitals. But so we need to understand that, because you want to prevent women from being undertreated or overtreated, because that can have serious outcomes either way. But also it is important to monitor blood pressure. And so we're measuring women's satisfaction and adherence to measuring their blood pressure at home using Bluetooth monitors. We're in a very rural state, and it's hard for women to come in for monitoring. 43% of our population is rural. And so we're trying these monitors to see if they will adhere to it and if they like using them during pregnancy, so that the physicians and the providers can get better measurements to follow their blood pressures during pregnancy. Thank you.
Thank you. Dr. Granger.
Hi, everybody. Thank you so much for the opportunity to be here and join this panel. It's an impressive group, and I'm really honored to now be here as a part of it. My name is Brady Granger. I'm a professor of nursing at Duke University, and I have a joint appointment at the health system and run a hypertension clinic at our federally qualified health center, as well as an in care downtown. And the Heart to Heart grant that we were awarded this year in 2021 is entitled Improving the Visibility of Women Through Peer Partnerships. And our objective with this project is to increase the engagement of women in self-monitoring, and also to meet our National Healthy People 2030 quality metrics for blood pressure among women, which is to improve not only access to care, but to improve control of blood pressure. And I think it's great how these grants seem to segue and kind of go together. So that's kind of nice. So we can build on one another, I hope. But the work that we hope to do is a part of a series of building blocks in working with women, particularly women who are representing minority groups and low literacy, low income groups in our community. And we've really hard on issues like the digital divide to help them understand how to communicate with providers. Back to Erica's, Dr. Spatz's project, we've really focused on helping women understand blood pressure and have the skill set to self-monitor that blood pressure and understand a trend and what that means and when to call for help. So there have been a number of small projects along the way that we've used in really identifying what is our largest gap and what can we do in this situation to address that with the grant. So we're very excited to have the chance to take the next leap with our women, particularly in minority groups here in Durham, North Carolina. Thanks for having me.
Thank you so much. I think you all have started to share a little bit about, but our first question this evening is, in 3 sentences, can you please describe how your research has impacted women? And I don't know if Dr. Spatz wants to go first. We can go in the same order if that works for everyone.
Sure. I hope that what we've aimed to do is to validate the things that women know about themselves and care about, and allow them to feel comfortable and give the import when they're speaking with their healthcare providers. That includes concern about their family history. It includes the experience of stress, whether that's due to financial stress or discrimination or racism. These things we know impact cardiovascular health. It may also include people's mental health, like depression or anxiety, which again, we have very good evidence that that impacts cardiovascular health. It also may include concerns about medications. It may include the disutility of taking a medication every day, the inconvenience of that, feeling like you need to run to the pharmacy all the time and go get your labs drawn. All of that impacts adherence. It impacts the reasons why people decide or don't decide to take medications, except that people are doing that on their own and not with their healthcare providers. So I hope that our tools give credence to what women's experiences are and give them the words and the support that they need to be empowered to have more meaningful and rich conversations with their healthcare providers.
Great, thank you. So my research in this area took a little bit of a different spin. So as I mentioned, this new high sensitivity troponin assay was approved for use with either the combined cut points or the sex-specific cut points. But then hospitals across the US are rapidly scrambling to implement this, often done by laboratory scientists and medical lab directors who don't have direct patient contact. And they're left with the decision, well, do we use the combined cut points? Do we use the sex-specific cut points? Do we leave it up to physicians to just figure this out? So there was still, even though there were two sets of cut points, there was not a lot of clear guidance on which one should be adopted or how that choice should be made. So our goal in this study was to provide at least some data to support hospitals, laboratory directors, cardiologists, emergency physicians who are faced with that decision, to provide them with some data to guide that decision. And that's what we were able to do with this study, was to kind of compare the impact of using combined versus sex-specific cut points on patient diagnoses, at least, to ensure that everyone, both men and women, gets the highest possible care when they come in with a possible heart attack or heart injury.
The goal of our study is really to improve the diagnosis and treatment of preeclampsia in women. And so preeclampsia is one of the leading causes of morbidity and mortality in pregnancy, even though it only occurs in 5 to 10% of pregnancies. A study in California showed that 92% of the deaths due to preeclampsia were due to delays in diagnosis. And so it's because the signs and symptoms are kind of similar to normal symptoms of pregnancy and things that happen, headaches, swelling. So sometimes women ignore those, or they're not taken seriously by their providers. But if you have the data to say that, look, my blood pressure's been up for a while, or, making sure that when they're taking your blood pressure, it's taken the right way to know if it is actually high or if they're not doing it and it's low. So we really want to improve that for women so that they get the proper care.
Great. The goal of our project is to improve hypertension among women, and specifically because women have almost, African-American women in particular, have a 42% rate of all women to be hypertensive, whereas white women is much lower, 29. And our objective is to not only decrease the disparities and eliminate this gap, but to do it through training women to be leaders of health in their communities and neighborhoods through this three-pronged process that we've been testing. The first is the peer partnership, helping women match themselves with a peer of like socioeconomic and cultural context in their neighborhood, to train that dyad or duo to be able to self-monitor accurately, to use the EHR for reporting blood pressure accurately, and to communicate accurately what their needs are with regard to medication access, provider access, or other important issues that they need to support their health. And then the last prong is to train these women to become leaders in their families, as we know women are, and to really be able to speak out confidently about hypertension, the importance of hypertension and controlling that blood pressure in the prevention of stroke, and the value that it has for the whole family, and just educating others through the women and the leadership skills that the women will gain, we hope. I think that was more than 3 sentences. Sorry, Jenny.
I'm sorry we asked you to just do it in 3 sentences. I don't, you all did a wonderful job, actually. Jennifer?
That was y'all's test for the evening. We just didn't let you know that was happening. So I was going to start with Dr. Mumma and Dr. Santillan. Can you talk about any of the interactions that you had with the collegiate or alumni members, and what has it been like working with them on your projects? I don't know, we want to keep the same order so life is easy, I guess.
Sure. So I think in a nutshell, it's been fantastic. I want to take a moment just to thank all of you for this opportunity. This has been such a fun and rewarding grant experience. From the beginning, just, I was able to meet several of the alumni members. We had an event in Napa that was sort of a more casual. I really was able to have a lot of one-on-one conversations with everyone. And then another meeting on the UC Davis campus where the alumni members were able to meet more of the faculty beyond just me, who were involved and continue to be involved with this important research. And in other grants I've received, it's more of like, it's much more formal. And it's like, okay, you've been selected, here's your check. But this has been just a much more fun, it really feels more like a partnership. And there's just been so much excitement and so much passion that comes from the organization that I've been able to feel. And it's really rewarding as a researcher to see so much passion from such a large, strong group of women supporting such an important cause. Even before I submitted my application, I met with our undergraduate Alpha Phi chapter at UC Davis, and they were fantastic and jumped right in. And we kind of talked about, the best ways that would be mutually beneficial for us to collaborate during this grant. And we ultimately agreed on some funded summer internship positions. So I included those in my grant. I opened it first for our local Alpha Phi chapter at UC Davis and had more than enough interest to fill those positions. So I didn't need to reach out to the other chapter that we have in Sacramento. We ultimately were able to select 2 outstanding interns who really were engaged in every step of the research process. They learned how to review medical records, how to manage a database. They contacted patients directly for the 30-day and 1-year follow-up. And then they worked with me on how to interpret the data. They both presented the data at conferences and were also included in the published manuscript. So really got to see the project through from beginning to end. For me, undergraduate is earlier than I get to meet a lot of the research mentees I work with. I usually meet them at the earliest as medical students. So it was really fun to meet them at an even earlier stage. And we've continued to keep in touch and provide mentoring both on additional research opportunities as well as just general career development. One is currently finishing her first year of medical school, and the other one is working full-time in a laboratory position. So I've also kept in touch with the chapter leadership at UC Davis. My grant started in 2019, and we all know what happened 6 months into my grant, COVID hit. So some of the events that we had planned for the spring that would have been able to reach more than just the 2 summer interns, but do some more mentoring and career development for all the people who are interested in pre-medical careers in the chapter have been postponed indefinitely by COVID. And we've talked about doing it via Zoom, but I think the agreement has been that we've had enough Zoom. So we are hoping for a late spring or early fall, more general career mentoring and advising session for the local chapter.
Awesome, that's great to hear. Dr. Santillan?
We're very fortunate that we have so many Alpha Phis as members of our student research team. So there's about 20 students on our research team in general, and 7 of those are Alpha Phis. So after we had the check presentation, which was by Zoom, and they found out that the University of Iowa had one of these grants, they reached out, and we've paired them up with students. So we always have 2 students come in together, and they work on the projects from the beginning to end. So they learned how to take blood pressures. They went around the lab taking lots of blood pressures. Everybody in lab has been very well screened many times until they could test out and that they had done it correctly. They've done human subjects research training. They are very involved in the design of the database, and they call participants and they do recruiting, and then they set up appointments for themselves, and they go and do the actual study, and they load the data, and then as it comes in, they will help with doing the data analysis, and they're all going to have little pieces of it that they can participate in and have undergraduate research posters and they'll all be on abstracts and the manuscripts. And we have a variety of students. We have some that are pre-nursing, some that are pre-med. One is a communications major. So they're all from different parts, but they're interested in health. And it's really rewarding for us because we feel like we're championing women's health research, and we're also helping to build the next generation of women's health researchers, because a lot of them hadn't really considered it as a career path. And they see that my co-recipient, Dr. Deborah Brandt, who's on vacation right now and couldn't be here tonight, she has a PhD in nursing. And so the pre-nursing students maybe hadn't considered that before. And I'm a molecular biologist, so some of the other people are learning that more about what it would be like to go to grad school, and they just see kind of all the different career paths that are in our department, but they all are learning a lot more about women's health and hearing me be on my soapbox about women being involved in research. But they're a lot of fun, and they bring life to the lab, definitely, and they teach us a lot. But it's just been great to have them be involved in the project from beginning to end. And COVID did unfortunately damper our ability to interact with the chapter. But thankfully we do have such a large number of students, so we get to interact with them that way. And we've made videos and kind of done tours of the lab for the rest of the chapter that way.
Thank you so much. That's always great to hear. We like to hear when, the collegiates are actually excited and getting involved. As a research person myself too, I always love to hear that, like, we're still, breeding that passion in the next crew and making them want to be involved and do more stuff. So the next question will go for the other two, for Dr. Spatz and Dr. Granger. We know that women, especially in cardiac research, are very underrepresented. Traditionally it's the VA older male patients that are always studied because it was the easiest people they could get, right? So it's, opportunity project. So for women of marginalized or disparate communities, did your research show any significant findings that you are using to launch forward? Dr. Spatz, you want to go first?
Sure, happy to. I think that the more that the more research I do, the more I realize that well-intentions aren't good enough. You really need to be very purposeful and to have a strategic plan to enroll a diverse sample. And so for so long, we've been, asked by NIH to make sure that we have equal representation with women or underserved minority groups. It doesn't happen on its own. And I think that in my research, including even with a strategic plan, I think that you need to be purposeful and you need to message why it's important to participate in research. There's a long legacy of distrust, especially among low income or people of color or communities of color groups because of negligence and really poor research ethics in the past. And so I think we need to overcome those that history, and we really need to talk about why it's important for women to participate in research, why the data needs to be reflective of people who look like you, in order for us to advance our care. So I think that the recruitment needs to really, really be purposeful. And then it's been so great to hear about Brady's work. I feel like there's a lot of parallels. In this model that we're using a peer model as well. So where one woman is the host and invites her peer group to participate in these events. And that kind of sharing of experiences and familiarity with people, even if not everybody in the group knows each other, other people have been invited, has facilitated much more meaningful discussions around very sensitive topics. And people can hear what other people are thinking and sort of say like, oh gosh, yeah, that triggers something for me as well. And it's not always the same. Like everybody doesn't need to think the same, or everybody doesn't have to come and walk away with the same thing. But I think it's helpful to create a space where people feel safe, they feel comfortable talking, and they can hear a diversity of opinions among people that they somewhat know or maybe know really well, And so there's a lot more immediate trust and respect for what others are saying in those groups. So, how has the research been informed by the inclusion of women and women of diverse backgrounds? I think that it underscores the importance of really personalized cardiovascular risk assessments and moving beyond what we know are the traditional risk factors to understand more of the social determinants of health. How does, living in a community where you feel safe, where you can go to sleep at night and feel rested because you're not stressed, where putting food on your table or, feeling like you can go out to the park and not have to worry about your children's safety, how do those things impact people's daily experiences, their blood pressure control, their ability to access medications or to really prioritize their health. Like, all of our work is so cross-cutting, but I also do a lot of work in the blood pressure space, especially with postpartum women. And, women are torn in so many different directions, whether it's, caring for your baby in the NICU, because most of those women with hypertension are delivered preterm and their babies are in the NICU, to women who are more middle-aged and in that sandwich generation where they're caring for their kids and caring for their parents. And so I think that, creating these diverse groups of women of all ages has really kind of expanded the work and the need for more personalized risk assessment, so that when I'm teaching my cardiology fellows and when I'm working to build a broader women's health program, that we're able to speak to the things that are important to women at different stages of their life or in different social or environmental contexts, and bring those into the medical conversation because they absolutely matter. If we only focus on the traditional risk factors that are right before us, I think we miss so many opportunities to improve women's engagement and allow them give them the skills to make good choices in their life to improve their cardiovascular health. So I guess, this work would really be nothing if it wasn't for, I think being able to include a very diverse sample and hearing about their experiences so that we can create more meaningful tools to facilitate these conversations.
Thank you so much. I really want to point out, especially with heart health, it's not a moment in time. It's the collective of all the stuff that they're going through and, taking care of their family and trying to balance work and stress and food deserts and, is it safe to walk down the street? I think all that is so, so important. So thank you so much. Dr. Granger?
I like going after Erica or Dr. Spatz because it's so great to dovetail the work together. So in our peer partnership planning phase, we did two things and again, the context where I am in Durham is predominantly African-American women at our federally qualified health center. And in fact, African-American women are the majority there at the clinic, and Hispanic women are the second most populous. But we have just here in our local little neighborhood, 8,000 people with uncontrolled hypertension, pretty severe, greater than 160 over 100. And so even in our small pilot group 2 years ago, we started off with 20 women, and there were 5 major cardiovascular events among that group of people by the end of the project. So it's a very high risk group, very low income and high stress, as you said, and they have a lot of responsibility, which we saw or decided to see as a lot of opportunity. They have kids, and they also take care of their parents and extended families. They have, it is somewhat of a food desert from their perspective. There's food, but not what heart healthy food. Certainly not food that reflects the American Heart Association, Simple 7. The groups are underrepresented in terms of food groups. So we decided to take this partnership approach, mostly to have these women who are, they're strong women. They're vocal. They have a lot of responsibilities. They juggle things actually fairly well. And so the idea of the peer partnership was something that they really latched onto and liked. And so in building the intervention, the two groups that we looked at first were the groups that had no digital access, and then the groups who had these multi-layers of family responsibilities. And so the digital access, just yesterday we were testing a different cycle of women with Zoom classes for blood pressure monitoring, and the skills that they've been building over time that started off at 0, I think might be ready to go by the time we're ready to start this project, where we want to do a good bit of the activities, at least at the beginning, on Zoom. But I was so happy to see that despite not having a device, many of them in the beginning, despite not understanding how to log on or enter a password or just simple things like that, we've been able to increase their representation in the patient portal of the electronic health record so far by 30%. We've been able to help them get on a Zoom and put the camera so that we can see the blood pressure cuff in position. And so some small steps, I think, among these women that started off in this group of people with very, very low access, low literacy, low low tech savviness was another thing that we measured. So I think the opportunity is to take their networks and their neighborhood cultures and turn it into something that works for them. And that is our main objective with the project. And I think it's one that so far in these small planning phases, we seem to see some hope.
Awesome. Thank you so much. It's so great hearing about all of y'all's projects and how things have developed and changed as time goes on. I'm sure Dr. Granger will be having lots more conversations as you start getting up and running. Jenny, do you want to do the next one?
Yes, thank you. So we do have a few questions from our audience. Dr. Mumma, this one's for you. With working in the emergency department, do you find that women are more hesitant to come in and be assertive when it comes to chest pain and heart injuries?
That's a great question. So anecdotally, I want to say yes. It's a little bit hard to tell because I don't know who doesn't come in. I only see them if they do come in. But I have had, even in the last few weeks, even I've had several women say, thank you so much for taking me seriously. When I called my doctor, they seemed like they weren't going to get me in quickly, or I was afraid I would come here and somebody would tell me that because I was a woman, or because I was a woman, or because I had a lot of stress, that my chest pain was just because of that. And I really appreciate you taking it seriously. So I think, those who have done the kind of the focus groups and the qualitative work may be able to speak a little bit more to that, because I haven't studied it formally, but I would say anecdotally, yes. I think our country for a long time has, as you all know, kind of portrayed heart disease as a man's disease, and women are starting to realize that it affects them. But we, in medicine, I think even though we know women get heart disease, there's still a little bit of a bias toward thinking more seriously about heart disease in men than in women. And the flip side, a little bit of a tangent, but I'm working on another study that's taking a similar approach, but looking at pulmonary embolism, which is another life-threatening cause of chest pain in the emergency department. And in contrast to heart attacks, we over-evaluate and overwork up women with chest pain who, when we think there might be a blood clot in their lungs, to the point that we're exposing them to unnecessary radiation. So we're trying to kind of balance this out where we think maybe a little bit more about heart attacks and a little bit less about blood clots in the lungs, and try to reach a happy medium. So we're giving the most appropriate care to women who come in with chest pain, regardless of what's going on.
Awesome, thank you. One of the other questions from the audience, Dr. Santillan, you spoke how various positions such as Fowler's versus Sims or any of the other positions can change your blood pressure recordings. How drastic of a change are you seeing between those, and how drastic is your change between like the office versus the hospital bed like you were mentioning?
Right, so we have enrolled about 100 women so far, and when we look at our data, which is an intermediate analysis, right, so we want to enroll more women to be more sure of our findings. But when you're laying on your left side, we see that as the most significant difference from when you're seated in the position that you're supposed to be in. So when they take your blood pressure, you should have an empty bladder. You should not have drank coffee within a half an hour. You shouldn't have exercised within a half an hour. They shouldn't be talking to you. You should have been like sitting for 5 minutes, not have rushed into your clinic appointment, sit down and they're going over your meds while they're taking your blood pressure or checking your phone or anything. You're supposed to just be resting with your arm at heart height, right? So these don't normally happen in clinic, but if you did it that way with your feet on the ground and your back supported, if you do that, the difference between that and laying on your left side in the hospital bed is about 15 degrees of 15 millimeters of mercury, which can be substantially different, and it's lower. We find that semi-Fowler's though actually is quite comparable to seated, and so for pregnant women in the hospital, there was no significant difference. And that could actually be really useful information to know that clinically, well, you're not going to be able to necessarily get a woman out of her hospital bed and into a chair to take her blood pressure, but you could have her with her back at like 45 degrees and her legs in front of her and take her blood pressure. And it would be pretty similar to what it would be if you took it in the other position. And so that's good to know, because you might be able to take a woman from her left side and have her seated for a few minutes to take a blood pressure.
Yeah, I can agree that I don't think any of us have had that experience going to our doctor and getting our blood pressure taken, especially while pregnant. You're already nervous about everything else. That just adds to it. Thank you. So this question is for Dr. Granger and Dr. Spatz. Why do you think there's a gap when it comes to women communicating with physicians about their heart health and medications?
Sure. So I think we're primed. One of the things that I work in a group of people, and many of the to do this project, many of whom are not physicians or even in healthcare, or they're not healthcare providers, but they're healthcare designers, which means that they're kind of watching the encounter with this sort of keen eye for like what's happening and how can we disrupt all of these patterns that are not helpful, similar to like taking a blood pressure, you know, in all the wrong ways. Like you can see these kinds of very predictable conversations happen. And so one of the things that happens in a traditional doctor-patient relationship is like doctors know how to be doctors, but patients know how to be patients too. So when a difficult decision is posed, people in general, but women in particular, tend to ask questions. And myself included, try to get to a more perfect understanding of the problem so we could really understand it in the thinking that that's going to help us make a better decision for ourselves. In that process, we sort of lose the whole reason of who are we and why we even came to this place in the beginning and what we were all concerned about initially, because we try to figure out like what's the right answer. And doctors are really good at giving answers, right? So we could tell you about research studies, and we could tell you about this nuance and this subgroup and this little like difference here, there, but we actually don't ever then get to like the real heart of about making a decision or what's hard about this situation. So I think that in our groups, we try to model this and try to break those patterns so people can experience a different style of a communication and try to prepare ahead of time the things that they feel are important in their life, what's relevant to them. You know, now that you've talked about it in a group setting, you can walk away with like, gosh, not everything in that we discussed in that hour-long session was important for me, but these 3 things were, and I need to make them a priority to talk to my physician about. We even do some role playing about how those conversations could go and how we can steer them a little bit differently. So there's probably a lot more psychology behind like why women are not, we're really good communicators, but we're not such great communicators to our doctors, or maybe we get turned away by the doctor too quickly when we're dismissed because of them thinking that we're not at risk for heart disease or that doesn't matter. But I think there's probably a lot more complexities to it, but I think kind of maybe in a similar way as like with the blood pressure, we're trying to pick out the components that are very predictable and that we can work around and build skill sets, like as Brady said, to really kind of empower women to then be agents of change, both for themselves as well as for other peers.
Yeah, I'll just add to that because I think the point is, and the question I think was, Jenny, correct me if I'm wrong on the question, but the question is focusing on what it is about communication that women hesitate or hang back. And I think that what we have seen so far, and similar to what Erica's saying, there are so many things important in these women's lives, and the priorities are simply hard to shuffle between getting to work or even having a job and getting your kids where they should be and getting your parents where they should be, and food and paying bills. And so the stress is astronomical, and having prioritizing health is not always the first thing that they prioritize. So when they come to meet with us or do a group hypertension visit or come to the clinic at all, I think they themselves have a hard time clearing their head and talking about health even for a minute. And so the idea of helping to train them the skills for blood pressure, the importance of blood pressure, the relationship of that to really bad outcomes that affect their family, like stroke. It's something that sort of, in a minute, it can reorient the conversation, help them, I feel like, tune in a little better. And then we also have learned to tune in better and listen better, and listen to, not just listen, but also be able to, from a little bit of a psychological perspective, to listen with a motivational, interviewing sort of lens, like to listen to what they want to work on, to listen to what they can do within their given resources. And so I think the conversation gets better when we recognize the limitations that they bring to the conversation. And then also when we realize the important thing is listening to what matters to them and working this health habits into that. So I don't know if that really addresses your question well, but making the conversation more bi-directional and less just top down, this is what you need to do, is part of it.
I think the word listen came to my mind when you both were talking, in terms of us listening to ourselves as patients and being honest with ourselves about what we're feeling. And I think as women, we tend to not put ourselves first. Self-care is a very popular topic these days, but it's true. And we can't help others and our families if we don't help ourselves. And so we're not being selfish. We should take care of ourselves and be able to listen to our bodies and be able to share that with our doctor, and hope that the doctor reciprocates that and is able to listen to our concerns. So it sounds like you're all working in that space to educate women to do that. So that's terrific. So we have one final question for all of you. Well, we have other questions that we're receiving, but want to be sensitive of time. We have one final question that we hope you will all answer. How has the Alpha Phi Heart to Heart grant positively impacted your research? I guess we can start with Dr. Spatz again.
So the Heart to Heart grant did a few things. One is that it brought me together with new colleagues and a more rich, diverse group of researchers. I was mentioning that we are using healthcare designers. And since then, I kind of feel like, gosh, how can I do work without them? They have so many neat insights that are so different from our usual, like, medical approach. And so it's really opened up the possibility for how to build really patient-facing, stakeholder-engaged research in a new way that advances the work. And what do I mean by that? Like, the art matters. Like, the pictures and images that you use really matter. And so I think like one of the wonderful things is, like, we worked with an artist who kind of portrayed these examples in ways that speak to women. And I think that that's of value. I think that that draws people in. Also locally, we have a women's health research at Yale section, and they have been very supportive of this work. And it has helped to also launch the careers of other people who are doing women's health work at Yale. I've gotten a chance to work with an Alpha Phi alum who's an OBGYN and working in the space of preeclampsia. So we are doing a lot of work together that stemmed from this work. And I related to Bryn's work in the emergency room. We're kind of looking into other ways to diagnose heart attacks in the catheterization lab, really looking to see if women are having spasm or other kinds of microvascular disease, which can present acutely like a heart attack, or can present just with chest pain, and women are turned away all the time saying your arteries are normal. So all of this is kind of motivated from some of the group's discussions, but it also has just given us visibility at Yale and among other people doing this work to kind of launch out into other areas to do more research into women's cardiovascular health.
Yeah, I'm going to echo many of the same sentiments. I mean, at a very concrete level, the grant made possible the study that we wanted to do and put that information out there. But it also created a 1,000 patient database that we now have, that we are joining together with some collaborators in several different European countries to look at using troponin plus some clinical risk scores to identify patients at the highest risk of cardiovascular disease. And I think, funding in this area begets more attention and more research funding in this area. I've had a similar experience at my institution because of this and some other work I've done looking at gender differences in cardiovascular disease. I'm now mentoring some junior colleagues who are branching out in pulmonary embolism and cardiac arrest and other cardiovascular diseases that are highly relevant to women's health. And I also chair our diversity, inclusion, and equity in emergency medicine research subcommittee. So we're doing a lot of work. I bring more of the gender lens. Others on the committee bring more of the race and ethnicity lens. And we're looking at the intersectionality of gender, race, and ethnicity in a lot of our research studies in cardiovascular disease and even beyond in other topics in population health and emergency medicine. So I think this is one small step that really launched a cascade of events that are really enriching research in cardiovascular disease and beyond for women.
For us, it has brought more attention to women's health. We already had a large women's health research group, but more people have gotten involved. And so we've been able to focus on some new areas as well. We've been able to take our preliminary data and use it to submit larger grants so that we can expand our study. And because we've been studying the period during pregnancy, we've also been able to take what we've learned about women taking their blood pressure at home and using those monitors and issues with technology, whether it's because they don't have Wi-Fi at home or they don't have fast enough internet in general, or having the devices, and apply that to our studies in the postpartum period where women who are also at risk and need to be monitoring their blood pressures. And like we've talked about, women don't always prioritize themselves and their own health. So about half of women won't go to their 6-week postpartum checkup, which is really important if you had high blood pressure during pregnancy, important in general, but especially if you had high blood pressure, to come in and get that blood pressure check. And so if we can help women monitor their blood pressure at home, and maybe now we're doing a study where we're texting in blood pressures because more women have access to that and the speed of your Wi-Fi doesn't matter quite as much. So we're able to compare these methods and see what women prefer and what they adhere to better. And so really be able to build on the current study, which is still ongoing. We're really thankful that we have 2 years for the grant because COVID did eat up a little bit of our year and our ability to bring in patients and to do our study. But we're able to apply it to the next step in a woman's life as well. And so we're very excited about that.
I think for us, it will be to build on our current student population that's involved in a lot of these projects at Duke, and to really expand to include the Alpha Phi students and women across a number of camp. We have a couple of chapters here in our local area. So using the grant to, as we've all talked about, I think already, helping new learners learn, mentoring women in and growing the ability to disseminate the results and the impact that women can have leading their own health among the student group. Anyway, I think expanding the work not only to the patients, but also to the students who are involved is a huge opportunity, and I look forward to it.
Thank you. It's so nice to hear that through the Heart to Heart grant, you are able to get additional grants that will help move your work forward. So it's really wonderful for Alpha Phi to be a part of that and to increase the reach to the community, which is really one of the reasons why we do this work. So thank you all so much. So I want to thank our panelists, Dr. Erica Spatz, Dr. Bryn Mumma, Dr. Donna Santillan, and Dr. Bradi Granger for taking the time to join us and share with us the impact of the Heart to Heart grant on their pioneering research. And as we wrap up our program this evening, I would like to again express our sincere gratitude to the Alpha Phi Foundation donors and our volunteers. And without your dedication, this impact on women's heart health would not be possible. Due to the persistent dedication to advancing women's lives through the power of your philanthropy, Alpha Phi Foundation is well positioned to raise $38 million in comprehensive commitments. Leading with Heart is Alpha Phi's greatest philanthropic effort to date and focuses on building endowment funds with its mission to increase the perpetual resources for leadership, scholarship, and at the center of our conversation this evening, women's heart health. Leading with Heart will endow the Heart to Heart grant at $100,000 per year and sustain funding of cutting edge research and promote programs to educate, empower, and save women's lives. The next event in our Leading with Heart Impact series will be this summer, and it will be to celebrate the Foundation's impact on scholarship. We will hear from Foundation scholarship recipients of the past and present, learning how receiving an undergraduate or graduate scholarship changed the course of their academic, professional, and personal trajectories. And to learn more about Leading with Heart, we invite you to visit our website as well as follow us on Facebook, Instagram, Twitter, and LinkedIn. Thank you again for celebrating with us the Foundation's impact on women's heart health. And thank you so much again to our panelists this evening. It was a wonderful conversation, and I wish you all a wonderful night.